Hi, everybody. Welcome to the Optometric Insights Show, where we're going to fill your brain with clinical insights that you're going to be able to use in your offices and hopefully care for patients better. We also love feedback as well. To shoot us feedback, send us information that you're thinking about after the show as well. So today I'm going to be talking with the man, Dr. Dave Kading. Dave, I understand that you have a pretty interesting case to share with us. So share it and let's all learn from this.
Yeah, buddy, this is really a pretty typical case that we see most often. And, we all see dry eye patients in our practice, and trying to identify where we go with treatment can be a little bit tricky, particularly with all the diagnostics. I mean, as we looked at, and I recently counted the number of diagnostics that I didn't have when I was in optometry school that we now have with dry eye, looking at the treatments and the different types of treatments that are available that weren't available when we were in optometry school, 15 years ago, 27 in your case or whatever it was. But it can be kind of tricky. And I think that more and more we're realizing that the difficulty that people are having with diagnosing and treating, as you and I have gone around the country and have talked to a lot of clinicians and asked, well, what's your dry eye treatment of choice? It tends to be that somebody kind of picks up on one treatment and that's kind of their go-to for everybody. So we've kind of boiled down here in the practice something that streamlines that a little bit easier. And I recently had a 25-year-old dry eye patient who came in who had been to a couple of different people and had an interest in wearing contact lenses, and was uncomfortable at the end of the day with her contact lenses. And she had shared that she had tried all of these daily lenses, all of the monthly lenses, and had been refit several times. Well, come to find out, she had worn 2 or 3 different types of contact lenses, but thought she had tried them all. And was just kind of fed up and wanted to be in contact lenses. And so she, sought out our dry eye clinic. And, looking at her eyes, I didn't see any fluorescein staining. I didn't see any lissamine staining for the most part, except kind of along the lower lid margin. And when I averted her lid a little bit, I didn't even avert all the way. I saw the line of the lid wiper region had a little bit of some inflammation. And, you can see that with lissamine a lot easier than fluorescein. And so one of the big takeaways that I've had in my dry eye evolution is the value of lissamine as my primary dry eye stain. So then what I did is I looked at her lid margins and they looked great. I didn't see any sign of, any sign of redness or irritation, telangiectasia, or anything along those lines. But I used my Meibomian gland expressor, and I saw that her Meibomian glands were not yielding very much liquid secretions.
You gave me one of those 6 or 7 years ago, and to this day, it is probably one of the best clinical tools. When you start using that thing regularly, you realize how much you took for granted the functionality of the lid margin. So thank you for that. And for those that don't know what a Meibomian gland evaluator is, can you explain it just a little bit? Because I think
so it kind of looks like a little USB port that you might have, and you set it on the eyelid and you press, and it shows it's kind of like a little spring, and it exerts about 1.25 grams per millimeter squared of pressure, which is equivalent to a forceful blink. So by pressing on the eyelid with this instrument, if oil comes out, you know that with a forceful blink, the patient is yielding some liquid secretions. And all the studies utilize this instrument to differentiate whether a patient has MGD or doesn't have MGD. And so what our kind of takeaway from this particular case with this patient was that she wasn't yielding hardly any liquid. And as a result, any contact lens that she wore, she had friction as her eyelid slid across the lens, which was evident by the lid wiper region, having quite a bit of inflammation. So we did a thermal pulsation treatment on her. We have 2 of them in the office. We have both the LipiFlow and the iLux. And what we were looking for is that after treatment, the patient's Meibomian gland secretion scores went from little to far more. And they did. The patient came back at her month and a half visit, and she reported, I don't see any difference at all. And that's pretty typical. Usually it takes about 6 to 12 weeks before the patients are really starting to notice something, because it takes a while for those glands to start waking up again and start to flow. So I told her just have patience. I explained that ahead of time. And at her 3-month visit, she was saying that she was not noticing her contact lenses nearly as often at the end of the day. And the evidence kind of shows us that it continues to get better and better and better. So, kind of some takeaways for us is, one, consider utilizing lissamine green, looking for lid wiper epitheliopathy, and looking for a simplified way of telling whether the patient has MGD. And I think also, you and I have spoken all over the country, all over the world for that part, about contact lens discomfort. And really, it might not be the lens at all. It might just be that they've got decreased oil secretions. My patient was in her 20s, and she was starting to have this problem, which isn't typically a dry eye related age. So some interesting things in this particular case with the youth that she had.
Dave, when would you consider, so now thinking outside the box, because you obviously you treated the ocular surface, that was the underlying issue. Would you ever even consider maybe orthokeratology for this patient as opposed to a traditional kind of, I wear the lens during the day type lens?
Yeah, well, I know both you and I are big fans of orthokeratology, and I tend to reserve ortho K as a dry eye treatment for those patients who have such severe ocular surface diseases that wearing contact lens gives them blurry vision throughout the day. So, if she would enjoy the benefits of orthokeratology, of freedom from glasses daytime during the daytime, and not have to wear soft contact lenses, absolutely. And that isn't to say that I'm not a fan of Ortho K for everybody, but I tend to want my patients to be capable of wearing a contact lens in their 20s and 30s and 40s. If they can't because of an ocular surface issue, I want to treat that, not just switch them from a contact lens that they're in to something different.
So your philosophy is, one, let's make the ocular surface healthy, and now two, let's discuss the options with the patient and figure out with that discussion what's kind of the best route for them.
Yeah, and I think both you and I were guilty of this years ago, is that we would always just switch the contact lens, try something different, right?
We're a byproduct of our environment, though, Dave. I mean, when you think 10, 15 years ago, 20 years ago, what diagnostics did we have? What therapeutics did we have? I mean, there was next to nothing. So the only option we had was different artificial tears or different contact lenses. Now we're fortunate because we have more advanced lenses and more advanced diagnostics and more advanced therapeutics.
Yeah, yeah.
Great, Dave. Well, anything else before we close out, bud, that you'd want to add about this case, that you just kind of a nugget or two that you want
Yeah, well, I think one other tidbit is that I was able to tell whether her MGD was better or not based upon the observable evidence. I didn't just base it on her telling me. As I saw glands that were clogged, I did a treatment and I saw that they were improved. Even though she didn't think it was better yet, I knew it was going that direction because of the clinical evidence. And I think that's important in our dry eye cases, to be able to see that things are improving.
Well, Dave, thank you. I love what you've kind of really highlighted here, understanding the objective nature and the subjective nature. You too, Dave, you really kind of forced me and pushed me into these objective objectifying subjective symptoms, using the speed questionnaire, using these types of tools that we have to give patients a number so that when we're seeing them back, we know whether or not they're improving based on a number that they're giving us over that time period of experience. So thanks, bud. Well, thank you guys all for joining us for this episode of the Optometric Insights Show. Make sure you like us, follow us, ask us questions, give us feedback, and we really look forward to the next time we get a chance to connect.